Alors, bon après-midi à tous. Je me présente, David Eidelman. Je suis vice-principal pour les affaires de la santé et doyen de la faculté de médecine. Hi, my name is David Eidelman. I'm Vice Principal Health Affairs and Dean of the Faculty of Medicine at McGill. I want to, on behalf of the faculty and the university, welcome you to this inaugural Victor-Dzau and Ruth Cooper-Dzau Distinguished Lecture in Global and Population Health. I want to say thank you to all our students, alumni, faculty members, including the James McGill Circle, and everyone here for what will be the first of what I hope will be many great lectures in this new series, although I suspect we're starting so high that it's going to be a tough act to follow after this. I want to thank the organizing committee, everyone involved in putting together today's event. I want to a special shout out to Tasha Yinde, who's here, to Don Williams. These are the people, Tasha, Donna, people like that who did the work. I want to, of course, welcome Victor and Ruth, after whom this lecture is named, and I'm going to be introducing them in a second. I want to also give a very warm welcome to the International Advisory Board members of our new School of Population and Global Health. Dr. Dzau, who's the chair from Duke University, Michelle Barry from Stanford University, Myron Cohn from the University of North Carolina, John Frank from the University of Edinburgh, George Repchik from Columbia University, Sheila Jasanoff from Harvard University, Joanne Liu from Médecins Sans Frontières, Michael Merson from Duke University, and Chris Murray from the University of Washington. So today's lecture and the tremendous interest from everyone who's joined us makes a great first milestone for this school, and one that is made possible thanks to the Dzaus. And I have to say, we've come a very long way in a very short time in terms of the School of Population and Global Health. And I just want to, once again reiterate to all those who worked on it my real thanks for the hard work. Many of the people have been working on this for almost 2.5 years. The School of Population and Global Health is designed to unite disciplines, foster collaborations, and invest efforts in the fields that come under a wide umbrella that is population and global health. And we're particularly grateful that Dr. Dzau and Mrs. Cooper-Dzau, both McGill graduates, have recognized the importance of the new school by endowing the lecture we're about to hear. So you're probably wondering who they are. So Dr. Victor Dzau is a McGill graduate from the Faculty of Medicine, and he's currently president of the U.S. National Academy of Medicine and also serves as vice chair of the U.S. National Research Council. He's an internationally known and acclaimed leader and scientist who has made a significant impact through his seminal research in cardiovascular medicine and genetics. He's designed and led a number of important initiatives. These include the Commission on a Global Health Risk Framework for the Future, the Human Gene Editing Initiative, and Vital Directions for Health and Health Care. He's received 11 honorary doctorates, including one from McGill in 2008. He's chair of our International Advisory Board, as I mentioned before. His partner is Mrs. Ruth Cooper-Dzau, who is also a distinguished graduate of our faculty, having received her bachelor degree in physical therapy from McGill and practiced in Massachusetts for 10 years, but is now a community leader who's passionate and very committed to social causes. Last night at dinner, I got a sense of just how passionate and committed she is. She's very passionate and committed, and she's involved in such areas as the American Heart Association, the Second Step, which provides shelter, support, and vocational training to victims of domestic violence and their families. And since 2010, she's been involved in the creation of a museum to highlight the rich history of Durham, North Carolina, where she lives. She also sits on the boards of the Triangle Community Foundation, North Carolina New Schools for STEM Education, and was vice chair of the North Carolina Symphony Board. So it's with great pleasure and pride that I welcome Dr. Dzau and Mrs. Cooper-Dzau back to Montreal, and I'd like to ask them to come up and say a few words.
Hello, everybody, and welcome. This one? Okay. Victor and I are absolutely thrilled to be here. The response to this lectureship, thank you, Paul, has just been amazing and very inspiring for us. I think Victor and I can truly say that McGill launched us in many different ways, and our sort of take on where you graduate, what you've done in life, the opportunities that you have. When you're in a position to give back, you really need to give back. It's almost your duty to give back. So this is an enormous pleasure for us. And one thing I would like to say that we've known Paul Farmer for quite some time. And when it comes to global health issues, he's a person who got it a long time ago, understood the whole concept that health is not a guarantee. He certainly understood that the disparities in life are not something that are self-inflicted, that everybody should deserve an opportunity to good health. And he took it beyond the United States. He's done this globally, and there are so many people who have even never met him, but who owe him a huge debt of gratitude for being a champion of their cause. And I would just like to thank him enormously for that. One other thing that I would like to say is that in life, there are opportunities that you sometimes recognize and sometimes that you don't. There are people that you meet that can help you in so many different ways. And I'd just like to introduce Dr. Hannah Papias, because she was an enormous mentor to Victor. And I would just like to thank you from the bottom of my heart for that.
I know why you're here, Paul Farmer. But I have to tell you that we are truly pleased to be supporting this lecture, and also importantly, supporting a new school. This is a great vision, a vision that Dean Eidelman has and others with regards to where the future is. When he told me about the school and how it's coming together, I say, I get it. It's the future of health. And so it's just a great opportunity. I do want to say that a few things. You know, I think the purpose of all this is, of today, and having Paul here, is to inspire all of you, particularly young people I see in this room. I remember not only meeting Paul many years ago, working with him, but 2004, when I was just arrived at Duke as chancellor, a freshman, he came to Duke. You know, he is a Duke alumnus. And the book, Mountain Beyond Mountain, was a must-read for freshmen. It was scintillating. It inspired the entire campus. And I think that, imagine the school and his work can inspire all of you to pursue what I believe is right in terms of health equity and others. And so what I've learned through the years, through my mentor, Dr. Hannah Papias, my mentor at Harvard, Jim Braunwald, Paul's as well, and Marshall Wolf, is taking bets on people. And people took a bet on me because I was an 18-year-old from Hong Kong, born in China, and I'll never forget this. So you bet on the right people, like Paul, great things will happen. And I would just simply say that, you know, if you look at people that you believe in, and people like Paul, who's compassionate, dedicated, and real leadership, you can really make a huge difference. So Paul, thank you for being here to honor both Ruth and myself, and thank all of you for being here. I've said more than enough. I'm going to sit down.
Okay. Well, before you go, we have a small token of appreciation.
Oh, thank you.
You can't leave here without souvenirs.
Okay, good. Thank you.
So thank you very much, Ruth and Victor. So this lecture series gives us a great opportunity to celebrate changemakers and to learn about new trends in global and population health. It also allows us to recognize outstanding leaders and celebrate the scholarship that underscores our commitment to education, research, and service to our local and global communities. The title of today's lecture, The Future of Global Health, Three Big Issues, is both timely and relevant. And for each of you in this room, of course, the issues may be different, from access to healthcare, to climate change, to infectious disease, gender equality. And we talked last night about the importance of new technologies and really the way in which healthcare delivery is changing. But these are all inextricably connected. And so on that note, I'm going to invite our Director of Global Health, who dreams of having a department just as big and famous as Paul's, he told me, Madhukar, to come up and introduce our speaker.
Thanks, everyone. I'm absolutely delighted about three things. One is that we finally have a School of Population Global Health. Yes. And we have our first Global Health lecture series, thanks to Victor and Ruth Cooper-Dzau. And then we have Paul Farmer as our inaugural speaker. Couldn't get any better than this as far as we're concerned. You know, we often have to introduce people, and we sometimes say, this person needs no introduction. Should I really introduce Paul Farmer? So I'm going to skip the introduction, Paul, and invite you right up here, because everybody knows you and your life's work. So please come up.
Wow. Thank you very much, Mother.
So is the mic on? Is your mic on, Paul?
I don't.
Yes.
Am I
Yes.
Am I mic'd? Yeah. People always say this person needs no introduction, and then they go on, usually to talk about themselves. So I mean,
I should have done that.
I'm still stunned. I know I do.
I missed the opportunity to do
Madhu's
that.
special.
So this lecture is different because it's meant to be a conversation with Paul Farmer. So you can imagine I've been sweating bullets for the last several days trying to figure out what the heck am I going to ask Paul Farmer. So Paul, but as scary as it is to interview you, there's one thing that reassures me, that he and I are both TB guys. Now once you meet another TB person, there's barely 20 of us in the whole world. It's so easy to talk to each other.
Cycloserine.
Yes.
But I said we should use 10 gram, not 750 milligrams. This is how we talk to each other. So no wonder there are only 20 of us.
So I'm going to get you warmed up with a very easy question. So if you wanted a global health student or a researcher to read one book that might inspire them a lot, which book would you hand out to them?
Wait, you didn't tell me you were going to say anything about that. This is, you know, sometimes you learn so much by reading fiction. And I'm sorry, but the only thing I'm thinking about is a book that I would never recommend to them.
Now I'm really dying to know what that is.
Lord of the Rings.
No, I have been told that you have something special with Lord of the Rings. Now, I've watched them all, I've read them all.
I didn't say, I mean, the movies are okay, but we're talking serious literature here, Madhu. Can't believe you didn't put
I know who told me that. Jen Furin was here last week.
Oh, yeah, she would know.
So she told me and Rachel that you're huge on Lord of the Rings, and she was forced to watch it many, many times with you. And
she
whatnot.
was, yes,
Yeah.
yes. It's required to go to Harvard Medical School, so Victor says we need standardized credentialing. Lord of the Rings.
But really, which book do you think? Let's bring you back to global health.
Well, look, let me just say that one of the things that the McGill students could do. By the way, I so enjoyed my time with the students. Last night, many of them came, and I also want to thank Tasha for reining me in. I do what Victor says. We learned that. That's a motto at Harvard. We do what Victor says we want to. But thank you, you know, and David, but thank the whole team and for doing this. And again, since there are only 20 living, well, actually some of them are here in Montreal, the living TB experts, under 100. I can't say that again. But let me just mention a couple of teachers whose books I read. You know, I learned something from my mentor in medical anthropology. So you've heard about my mentors in clinical medicine. I mean, it's really quite something to go from rural Florida. So I'm going to back up.
Sure.
Shocker. The students, one of them unleashed a 10-minute answer today by asking about something that was in that film. And I said, well, that's not the whole story. Let me go back. My friends say this is paragraphs within paragraphs with footnotes on them. So before I tell you books that I liked, I just want to say, when I went from rural Florida, from a very small public high school with big family, and I said I wanted to be a doctor. Now, I've been saying that for years, after I read Lord of the Rings. Which, by the way, since you asked me why I had a thing about it, it was the first book I really ever owned. It was given to me as a gift for my maybe my 10th birthday, 5th grade, by some people who owned, kindly people who owned a bookstore. I mean, I didn't know many people who owned bookstores, and that's what they gave me. Now skip ahead, 18. I say to the guidance counselor at my public school, who we were not really very good to. Like, I later went back and apologized when I got tenure at Harvard. But she said, do you want to be a doctor? And I said, yeah. And she said, where do you want to go to school? And I shrugged and said, I don't know, University of Florida, Florida State, University of South Florida. If the University of Central Florida had a medical school, I probably would have said that. This was just what I knew, And she said, well, what about Duke or Johns Hopkins? And I said, well, where are those? She said, Durham, North Carolina, and Baltimore. You don't tell stories like that when you're young. You say, oh, well, I had this all planned out.
Mm-hmm.
But that's what Ruth was saying earlier. Things don't happen the way they think they're going to, and Victor said, and you can't plan your career ahead. I mean, would you have thought that 2 TB doctors would be sitting 3 weeks ago in Mumbai, in Delhi, and then here? Where are we again? I'm kidding. Montreal is amazing. Hey, je parle français. Personne ne m'a posé une question en français, mais c'est chiant quand même. To learn French and then have no one in Montreal ask you anything in French.
He's been wanting to show off his French since yesterday.
Yes. The least you could have done.
But
and you think I've lost my train of thought? I haven't.
Okay, so let's bring you back.
I'm not done.
Okay.
This is like an infectious disease consult, not a surgical consult.
Of an MDR TB case.
So anyway, Off I go to do. I had a great experience. I went and majored in biochemistry. That's what you did, and I liked it, right? I loved it, actually, especially biochemistry, And then I took a course called medical anthropology. So this is not the answer you thought I'd be saying, some grand work of fiction or nonfiction. And I did, didn't I? Did I mention Lord of the Rings?
Yes,
you
did.
But I took this seminar, I took a class called Medical Anthropology, and we read a book that was still in proofs. Now, how we got that, I don't know, but it was by one Arthur Kleinman. Physician, he was a psychiatrist, anthropologist, and I learned a lot from him from reading the book, which I love, but also I thought, he's a psychiatrist, anthropologist, well, that's what I want to be. And I wrote him, a senior, it could have been a senior or maybe a junior at Duke, to a complete stranger professor. He wasn't at Washington, he was at the University of Washington, Seattle, and had trained at Harvard and was headed back there. I didn't know that. And he wrote me back. Now, that taught me a bunch of things. One, pay attention to the reading and enjoy it, which, again, then I went to graduate school where we faked all of the reading, like fold up books to make them look read. I was stressed out about this in front of Victor and Ruth, but now I'm not. So, and anyway, the other thing that I really learned, and I learned it again from when I switched majors, senior year, from biochemistry to medical anthropology. So one, you write someone, and that someone writes you back. This is in the days, I hate to break it to the Montreal students, but there was no internet. And one. Number two, I had to make that switch. That meant my biochemistry mentor, his name was Barbara Shaw, she had to do what Arthur Kleinman would later do and say, look, you should do what you want to do. If you want to change your major from biochemistry, even though you show promise in that, then you should do that. Could be an anthropologist. And then then I really started reading. Really was, that sort of cracked open my world. I had a great mentor, did a senior's thesis at the last minute. But it was one of Arthur Kleinman's books.
Arthur's book.
Yeah.
I met a student of yours yesterday, and she said anytime she went and spent a half an hour with you, you sent her back home with a list of 15 books.
I also gave her books so she can give them back to me now that she's a McGill medical student.
Okay, so that was about books. So Arthur Kleinman's books clearly had a big impact on you. Now, in terms of people who inspired you, obviously Arthur is one. Who else played a big role in your shaping your career?
Well, what about the guidance counselor, Wendy Talone? You know, even though we were terrible, I mean, we're right. And I did go back to say I wanted to get on my hands and knees, and say, "Forgive me for being such a jerk." But she had been named superintendent of schools, so there was some justice in the world. Or maybe that's an injustice, like being named chancellor for health affairs at a giant place. So, but I mean, I start the accounting like that, you know, not to be smarmy, right? How my parents brought up, you know, how they fed 8 people in that tiny little space where we lived, I still don't know, and I think of that. And then, you know, you meet these people, you don't understand, you know, how much they're going to mean to you. Maybe they think you've forgotten them, like Wendy Talone. I didn't. Or the people who, you know, in my home county. You know, when I got into Duke, by the way, without even knowing where Duke was, I didn't say that for 10 years publicly. You know, it was a big deal in my hometown. People helped me. You know, they said he comes from a big family. You know, they don't have a lot of. And then when I got to Duke, I had these terrific mentors there, biochemistry. But I'll tell you, one of the things where I started having some real heroes was when I got interested in the plight of migrant farm workers in the migrant farm working stream, which went from Florida all the way to New York and west, but it went through North Carolina. And there were a lot of Haitians in it that year. I was in the class of 82, so 81, 82. And I started writing. I'm to this day not a good writer, an easy writer, but I take it seriously. It helps me. And I'll say this to the students. I think with my hand. I'm actually left-handed. Did I mention Lord of the Rings? So, you know, you think through problems. What did I know about the political economy of the migrant worker force? Nothing. But it doesn't mean you can't read, again, and write, and interview people. So I started interviewing people. I said, well, I speak French. Est-ce que j'ai expliqué que je parle français couramment? Et personne ne m'a posé une question. So, and I started thinking I could speak with the Haitians, which was wrong, you know. They didn't understand a word I was saying. And, you know, I started, and I met some amazing people even there, and I think they would be shocked to hear me say, like I met this nun, and she had worked with Cesar Chavez. And I had grown up Catholic, so needless to say, I didn't want to be meeting any nuns. No, I'm kidding. I mean, not about the growing up part. And, you know, it's just a different kind of person, you know, who devoted her, she was, I'm not sure, but she was pushing 70 anyway, and she was out in them with the migrant farm workers who were getting detained and arrested, and she was going to get them released or getting groceries for them. It was just not like anything I had seen before. And I thought, well, what a virtuous person. And she was a radical, was involved in organizing, you know, the farm workers, union organizing, right? And, you know, it didn't take me long to, you know, I graduated, I went to Haiti, but I thought of her You know, and then I started reading new things, you know, that I would never have read, you know, as a college student, like Gustavo Gutierrez, Liberation Theology. And I later wrote a book with him. Did I mention Lord of the Rings?
Yes.
So I'm just saying, you know, all along the way, and then Harvard was just like Duke, an accident. I thought, well, I want to be a doctor, and I mean, I won't get into Harvard. I didn't even apply to Duke because I assumed I would not get in. Their daughter got into Harvard and Duke and trashed us and went to Duke. But you know, it was not overconfidence. I only applied to one school because, again, my backup plan and assumption was I'll go back to Florida, the state schools are there, you know, and my father died right then, you know, when I was, you know, I was able to tell him, though, he dropped dead playing basketball. You know, who knows why, right? You don't have insurance, you don't have regular medical care. That's another thing, Haiti most of all, but, you know, you get touched by these things that are close to you. And I got to tell him, though, I got into Harvard Medical School. I was back in Haiti. And again, you know, I didn't consider myself in line to go to Harvard Medical School, and then more doors kept on being open for me. So when I look back with appreciation, it's really at teachers and people like Eugene Brownwald and Victor. I mean, actually, the day that I started my internship at the Brigham, or that or thereabouts, it was quite a day. I had already spent quite a bit of time in Haiti. I had an MD and a PhD. I was 31 already, older than most of the interns, although I would say half of the intern class had PhDs in addition to an MD. And I was only going to go to the Brigham because they wanted me to, right? And so there was, again, to me, that's that continuity from high school. And my parents wanted me to go to college, but they not like some kids whose parents are saying, you need to go here, you need to go there. It was just like, thank God you got into college. And, you know, my first day, I'd spent this time in Haiti years, and I'd learned a lot of hard things, hard for others. And I was on call, and there was a woman who was in respiratory distress. And I was saying, it was 2 in the morning, and I said to the nurses were great, by the way. What professionals, what amazing people. And they realized with interns, you know, that they don't know what's going on, right? And I said, you know, I think we need to intubate this woman. And they said, shall we call a code green? And I'm thinking, which one is that again? And I said, well, you know, where's the kit? They said, you don't have to intubate her. They said, there's a whole anesthesia unit, a whole team that will come here. Just let me call a code green. And of course, that's what happened. And I thought, I'm never going to complain about anything ever again. And, you know, I also thought this is the way it should be. You know, there should be hospitals like this in clinical deserts.
So this leads me to the question. We said 3 big issues in your lecture, but this is obviously one of the biggest issues.
Did you read them, the letter I wrote you back when you said 3 big issues?
I did. We have more than 3 big issues.
And I said, what 3 big issues are those? Who made that title? Madhu, did you do that?
So one big issue is something we discussed yesterday and today as well, is that 40 years after Alma Ata, half of the world's population still doesn't have access to what you and I would consider essential health services. Why is it that health is such a hard sell for country governments to invest in? I mean, take India, for example. You and I were there not too long ago. India barely spends 1.5% of the GDP on health, and makes all sorts of lofty promises of eliminating TB by 2025, when the Indian TB budget is practically nothing. So how is it that 40 years later, we kind of almost restarting the clock with this UHC campaign, And it's because of that underinvestment that people make these crazy choices that you were talking about. Choose between HIV and TB, choose between diabetes and HIV, ridiculous stuff, choose between prevention and treatment. Why is it that we are not able to push the boundary on universal health coverage?
Man, that's the second time. What's your favorite book? And please explain the actions of government bureaucrats. Madhu, we're supposed to be talking about TB or something. You know, I think about this a lot, and I know we've been lucky to think about it together. Why is it that political elites, I mean, I'm just using that term sociologically, why are they socialized for scarcity on behalf of other people, right? And if you're going to use the nation state as the unit of analysis, and that's what we do, right? It's like unthinkingly. And so I would read, for example, someone like Amartya Sen, or someone who's actually done research on why Indian elites, for example, because you brought it up, or Nigerian, you know, people who do have resources compared to some of the clinical deserts we've talked about, why so underinvest so dramatically in health care delivery, but also education. And then how can that be reversed, right? Yeah. Some people like you, and I hope I'm in that category, are willing to, certainly Victor is, are willing to say, well, we can push harder to increase that. So it can't just be just about lamenting it, lamenting the underinvestment. But I do think, and I made this argument today, perhaps not as compellingly as I should have or will keep trying to do, is that there's something important to be learned about reflecting a little bit beyond the past few decades if we want to understand socialization for scarcity on behalf of others. And, you know, to not talk about colonialism is just a huge error, right? Because, you know, look at West Africa and look at the rise of the disease control versus care logic. That begins in the late 19th century there, not in the mid-18th or what. Yes, there's horrible things that happen that connect us to West Africa starting in the 16th century, right? But the idea that we're going to create a system that is not about taking care of the citizenry, but rather the subjects, that really gets formalized at the same time that modern microbiology and public health rise, right? So at least we'd want to make those connections out of respect for people who have, you know, endured colonial rule. The Haitians don't have the same way of seeing the world. Yeah, they have a lot of problems, but socialization for scarcity on behalf of others is different there. And it's different in Rwanda, which did endure it, but you know, there was the explosive events of 1994 which allowed this rethinking. But you know, it's like when you're sitting in Mumbai or Delhi and thinking, wow, I mean, 300 years ago, this was the richest place on earth, generating 27% of the world's GDP. When the British left, it was 2%. Like, can't we have a little bit of respect? So I'm not excusing all the, why would I? It's not my job to excuse national governments in India or elsewhere. But there is a history to this chronic underinvestment. And it was a lot worse in the 19th century when there wasn't an independent India. That is, the amount of money invested in girls' education and primary education and secondary education and healthcare was even smaller. Meanwhile, I kind of thought it wasn't. I mean, I thought because there's this rumor going around, well, you know, it was better under colonial rule. I mean, it was more orderly. Things really fell apart after independence. I'm talking about, again, in general in the colonial world. And then you just kind of accept that stuff until you start reading the numbers and looking at the budgets and thinking about, that's not true, you know? And there it's great when you have a place like Rwanda where there's enlightened leadership post-genocide and they say, we're gonna put a lot of money, of the little money we have, into healthcare, education, especially girls' education and gender equity, and it shows. And I believe that's going to happen in India, and I believe that's going to, you know, we have the rebuke of tuberculosis, as you know, where India is the #1 in most cases. So I don't know why, but I know some of the deeper
so that
roots.
partly explains why your book and Joya's book, which just came out, begins the first chapter in Global Health as the history of colonialism. And it seems like that's something that your group genuinely has thought through and would like others to also learn about.
But you know, that's not an intellectual, I mean, in other words, Joya and I are tied by that engagement.
Yep.
You know, she's an infectious disease doctor also, but you know, I'm saying I would have gotten at this through anthropology, and she would have gotten at it maybe through public health. She has an MPH.
So
but we got to the same point because it's important to
sitting
acknowledge.
here in Canada, we also have similar issues. As you know, our indigenous communities and the history of how they were treated still echoes today. The fact that we have a TB problem that's 60-fold higher than the rest of Canada tells you a lot about how diseases persist. So in this environment, I'm sure you saw The Economist about 3 weeks ago on universal health coverage.
Oh yes, I did see that. I was going like,
I know.
didn't see that either, but I did.
Imagine, Economist. So
Madhu, what are you talking about? Oh yes, I did read that.
So it seems to me that today, if you want governments or anyone to invest in health, you almost have to make an economic argument as to why it's a good thing to eliminate TB, that if you invest in TB, you will get $1 trillion benefit for your economy and whatnot. And every disease is now required to make a business case, that you need to invest in diabetes, you need to invest in mental health. So it's becoming to a point that the whole idea of health as a human right somewhere is getting eroded, that we always have to make an economic argument. So how do you deal with the fact that you and your team, PIH, genuinely has advocated for health as a human right that just needs to get done, right? Versus this new way of, the economic lens of making an argument.
Well, you know, to me, it's not versus. I actually think we should make the economic arguments as an exercise. I mean, there's some of the titans of global health here who've worked on this, and we agree. I mean, we've done it too. It's not, and some of the students, your wife was there, and it was a great discussion. I hope, but we're talking about why would one make these arguments? Victor was there too, and he said the same thing. I think it's a very sound exercise. It does not replace the notion of rights, right? I mean, that's a safety net notion. If I'm talking to a head of state or a minister of finance, you can bet I'm going to have done a little bit of homework on what the return on these investments might be. So I'm saying I think we should do that too. Yeah.
We should do both.
And then there's a second set of arguments that are very well known here. And you know, this school is exciting because if it brings all McGill together, which is very hard to do in a university. Victor has done this at Duke. It's not easy to do. Universities are naturally fractured kind of institutions. Sure. But population and global health, when it involves global health equity, is just the kind of thing that we need to update the old public health.
So let me ask you a
But
question.
let me just say this one thing, is that if you have the economic arguments not down, because you can't get them down, they're not based on real data. It's kind of like Lord of the Rings, you know where it's going, right? And then you have a series of arguments that we've also used a lot, and you know, I'm looking at Mike Cohen, is, you know, public goods for public health. You want to be safe yourself, whether you talk about national security or talking about an outbreak in Montreal, of TB in Montreal, you better be thinking about public goods for public health. And the more we can expand that, the right to communication, safe roads, public safety, the right to listen to Arcade Fire. You know, that's the second model. And then we have our safety net. You know, well, you know, it is a good thing to have a right not to die of a treatable or preventable disease because you're poor. So I think all three of those levels of arguments that we as citizenry, and certainly the students in a school like this, and medical students and nursing students also, we should learn those.
So going back to this issue of universities, right? So the school we have, you're an academic, I'm an academic. You've written in your book more than once that global health needs to be more than just a hobby for those of us who are in academia. So if that is the case, it demands that universities actually make a serious investment in global health. Otherwise, it will remain a hobby. And that's the risk, that we send our students or we ourselves go somewhere for a week or two, we come back. That's good. We do that kind of humanitarian or volunteerism kind of work. But if you want to do serious global health of the kind that you've done now in, 10 countries, how did you manage to pull off that, staying in academia and yet doing so much on-the-ground work, clinical service delivery, building a school of public health in Rwanda? How do you do both, and what investments does a university need to do to support people like you who want to actually move the needle on the ground?
Well, first of all, I mean, the first thing I have to hasten say, as you well know, is that if you want to do work like that, you work with a big team, right? And if you're in Haiti, they ought to be Haitians who are committed to health equity there, and the list goes on. That's not a nationalist argument, right? Although I would respect Haitian nationalism more than some others. That's an argument that you're committed to one of those three paradigms. And for a lot of partners and health co-workers, it's the right to health care paradigm, but they're also familiar, my colleagues in Rwanda and Haiti, and they're familiar with public goods for public health arguments and the return on investment arguments. So that's the main thing. It's like, if I disappear to be on service at the Brigham or to teach a class, my day job, nothing's going to happen to services in these places, they don't depend on me. And I was explaining to the students today, I do the clinical work because I need it. Some people are so centered and focused on the prize where they're going. It could be health equity, it could be a new TB vaccine, it could be a new anti-tuberculosis agent, it could be HPV vaccine, it could be renal transplant. That they can do that without that constant reminder, I worry that I'm not that good.
Do you still see patients when you go?
I saw patients after I left you in Delhi. I went to Mumbai and I saw
in Zarir's clinic.
In Zarir's clinic, and Zarir Dwadia, another great man. What I didn't say is, that I've said already, is that all along the way, along that trajectory, you said, how did I do that? Well, I was permitted to do it.
So Harvard
means Arthur Kleinman, Eugene Braunwald, Victor Dzau, the deans of Harvard Medical School, and finally, I must say, the president of Harvard University, Drew Faust. All along the way, do you know what it means when you're in the middle of the misery that was Haiti after the earthquake, to make your first trip back to your home university to give a talk at Harvard Medical School and have the president of Harvard come all the way over there? It's typical for me. It's like they've always been enablers. And people who want to do that, and that'll be the same here. You're going to need the dean. You're going to need, I believe you said, the principals. You're going to need your department chair and your division chief. I'll be damned if I forget what people did to me when I look at my colleagues and students. I won't do it, and I won't do it in Haiti or Rwanda, where I also have students. So I learned from these people, to build the kind of career that you want, if it's called a career or vocation, you need help all along the way. And sometimes I think we're encouraged to forget all the help we receive because somehow that's demeaning, or you're not as good as you think you are. Well, you're not as good as you think you are. Not you, Madhu. You're actually as good as you think you are, and then some.
So somewhere along the way, you mentioned the whole nationalistic. So the big issue for all of us in global health is, as America becomes more and more nationalistic, global health funding is declining, and we know America is the biggest, most generous donor among all countries, bar none. So and Canada's ODA isn't great. We are kind of flat. We're not doing enough for international aid by any metric. Brexit, all the drama happening in EU.
Well, there's some good Indian jokes about Brexit. Wait, we could have done that?
Did you pick that up in Mumbai?
Sorry. I'll behave, Victor.
if
Ruth will approve of that. Ruth approves of this message.
And Laurie Garrett was here last fall and gave a doomsday talk about global health in retreat. And it does feel like it is in retreat in many places. So if the rich part of the world is going to cut back on global health, who is to pick up the slack? And where do you think countries most affected by whichever disease will step up and take greater ownership? For example, why aren't the BRICS countries taking greater ownership on TB?
Why aren't they, or
why aren't they?
Yeah.
Right? 45% of the world's TB is in these countries, and they have the financial ability, and they have the smart people. They can do a lot more than they're doing right now.
They certainly can, and so I assume that you don't mind these meetings so much. Me, the meetings, in Delhi and Moscow. But do note, we note that the heads of state came to these TB meetings. I would not say that we're the most scintillating people in the world, the TB community.
I agree with you.
So I'm optimistic. It's not right, but it's been said a lot. And China obviously is a titan and it has economic might that's unrivaled, right? So, but I wouldn't bet against the Americans, meaning the United States. I wouldn't, because it's not over till it's over, and it won't be over, because look at, some of the crown jewels. That's an unfortunate metaphor after talking about the Raj, but some of the I would say the crown jewels of my country are the universities and the NIH. So
they haven't cut back on global health.
And they might, but then again, we won't. They might feel tempted to be socialized for scarcity on behalf of others, but we won't. We can't let that happen, because, we can say, well, it's kind of like going to the Brigham to be on call, and people are saying, or we have so many patients and so few clinicians. I said, well, we have so few clinicians. We just happen to have more than any other hospital on the face of the earth. I told you I'd never, ever complain about that again. Right? We have 11,000 faculty affiliated with Harvard Medical School. 11,000. We have time to put new commitments into explaining to the American people what things like this have done. PEPFAR, I don't think a lot of people thought that it would be George Bush who would make the largest commitment to global health equity that the States has made.
Absolutely.
Right? Again, do you think anything like that happened under colonial rule? It hasn't, and it couldn't under colonial rule. And yeah, there are a lot of problems, but I wouldn't bet against the Americans. I know the answer to your question is we need more investment from the so-called recipient countries, right? Rwanda's doing that. 20% of its public budget. But we have a long way to go in some of the other places, including, India, where, as you mentioned, if you're going to use that metric, which I think is a fair metric. But I don't think we should forget what this happened in the past.
What do you think Canada can do in this rapidly changing climate and politically, and where do you see Canada fitting in the global health landscape?
CanCon, Canadian content. I learned that term from Arcade Fire's Marika Shaw, who was here. You're not supposed to invite your foreign guests to say stuff like that.
You can say nice
I will.
things.
I will. Being a Canada fan, I will say, I believe that Canada, per capita, gives more money to Haiti than any other country on the face of the earth. And by the way, the Americans, more than half of all American households contributed to earthquake relief in Haiti. So that says something good about both those countries, right? Yeah. Now, it's true that Cuba manages to send more physicians to help out on clinical problems than either Canada or the United States, per capita. But Canada does a lot. Now, the question is, or a question, excuse me, you have a progressive foreign policy, as stated, right? But, you know, I'm not Canadian, but the first thing after stating a policy is how do you implement it? How do you make it make a difference? That's a lot of wealth, right, on both sides of this border. But where, you know, if you're making those kind of commitments, I would say people should be satisfied that they're making an enduring difference. And we're talking about Haiti, so you can look and say, okay, well, what is the impact of this on Haitian institutions, right? And that's a tough metric, but we should apply it. And you know, I hope that gender equity, health, education don't fall off the Canadian, you know, again, foreign policy seems like a cheap word because we're also talking about indigenous people here who have been in the past treated like they were a foreign population, right? So
there was a Lancet Commission on Canada, just came out a few months ago, and it basically said...
There was a Lancet Commission on beer in the 19th century, so...
I missed that one. So the Lancet Commission on Canada basically said Canada has all of the right ingredients to step up in global health.
Yeah.
We're considered a middle power, an honest broker, just a good citizen and a great reputation, but we need to fix two things. One is we have to address the indigenous health disparities. Otherwise, we don't have the global platform to stand up and speak about global health. And two, we need to spend more on ODA, foreign aid, which is just really at the bottom of the developed country list. So
I think that surprises a lot of people because when you come here, as I have, and you know Canadians, you know that they're generous and giving, and again, it's just going through channels that are different and for reasons that, you know, everybody, the individuals have a right to do as they please, right? And I think it's good to use critical self-assessment too, no matter what the source of.
In fact, that article, Lancet series, was written all by Canadians, and it was so humble and apologetic that everybody said,
they knew.
"Oh my God, this has to be Canadian, right?"
But back to your indigenous people.
Didn't oversell Canada at all, huh?
Back to your indigenous people. You know this. You know, you could certainly. I'm not speaking as an American who say, "Hey, look how great." So we have the same problem. And again, these are post-settler, post-colonial societies, right? Yes. And restoring history, just like it's important in India or West Africa, is important on our continent and the one south of us too. And again, you know, people say, why go back to the past? Well, because just listen to people, and they'll actually tell you, please, you know. The standing of the United States in the Cold War on civil rights, it was just so easy to say, well, I mean, you've got Jim Crow. And so we did, right? You can't even vote if you're black and live in the South. How can the United States have a credible voice in human rights when the people who helped build this place don't have political rights? So, you know, and again, I would say the answer is we didn't. That doesn't mean we couldn't. Yeah. And, you know, I think the reckoning, historical reckoning of the Truth and Reconciliation process has, I think, been very moving to me from outside as a FOC fan of Canada.
You know, Bono was here last year, the year before, for the Global Fund Renewal, and he told all of us that the world needs more Canadas. That was Bono.
I can sing the whole national anthem in French. Can he?
We'll save it for the end.
Canada.
Okay, so let's talk about Ebola, Paul. So it's back, and as of today, it's killed 19 people, is what I saw, although the numbers are all fuzzy right now.
Yeah.
Everybody seemed to be responding way more quickly than last time around, and is Joanne Liu in the audience? There she is.
Joanne, big hug.
So she was on the call with Tedros. Tedros was in DRC 2 days ago. It's all happening, and we have a vaccine this time. We have a fantastic diagnostic test this time. But what explains the fact that we can't seem to prevent these outbreaks? what did we learn from the last round, and what could we do better this time?
Well, you know, it's kind of disturbing just to read the press coverage, right? And Joanne would know much more about this, but one of the things that I think we learned, and you know, you want an emergency physician on your side, and Joanne Liu has written very beautifully about this. It's a very painful topic, you know, is that you really do have to think about the quality of care, right? You know, we're going to be talking about what happened in West Africa for decades. I think it's the right thing to do. You know, when you look back at John Snow and cholera, you know, as my brother, who was a professional wrestler for 10 years and as a friend of Victor's said, not John Snow again. But, you know, Ebola, you know, if you start looking at the burden of disease, of malaria, et cetera, TB, with Joanne and I was lucky enough to write an article with Joanne on leaving, on the plane, on leaving you in Delhi. And, you know, Ebola is more of a symptom of something. And the West African story is painful because with the exception of Doctors Without Borders, really the whole world was late. And I would not go after the Ghanaian health authorities or, you know, I happened to be in Sierra Leone in June, which I'm a little embarrassed to say because you could say, well, you didn't get back there until October. It doesn't matter if I'm there, right? One person doesn't have the staff, stuff, space, and systems that's necessary. I was there for a surgery meeting, you know, but I knew when I left Sierra Leone on the last day, and my wife was with me, and we went to visit at the invitation of some friends. I only knew 4 Sierra Leoneans when I went there in June. And by November, 2 of them were dead of Ebola, both physicians. And the first one was the hardest because you saw the slow motion unfurling of this process. And again, with the exception of MSF, there really wasn't a lot of action in the summer of 2014. I went on this last day to the main teaching hospital, a colonial relic called Connaught, which was built in 1914 or something. It looks it too, you know. And I had just met a fantastic Spanish infectious disease doctor, a young woman. I mean, they all look pretty young to me, and 2 British guys who were working with the head of the hospital and others. The head of the hospital, of course, is Sierra Leonean, but he'd been to visit us at Harvard. In fact, I met the Brits there too, you know, and he is, I'm glad he's alive, he's a urologist. And they said, you know, come and look at, we're putting together this Ebola, they may have said holding unit, you know, I knew it wasn't a treatment unit when I got there. And to get into it, you had to go through the same entrance to the emergency ward. And there were these 3 young nurses there, Sierra Leoneans. And so it was those 3 Europeans, 3 Sierra Leoneans, and we were visiting. And there were these 6 beds divided by these grimy sheets of plastic and a bucket, and you know, there's nobody in there, right? No patients. And you know, I was thinking, when you have 6 people in here and shit and vomit and chlorine, it's just not going to be tolerable for 5 minutes, you know. And you know, I just left. And, you know, you have to leave Sierra Leone. You have to get on this. The airport is absurdly sited, right? And it's got to be for one of the British contributions to the extractive trade. Why would they put the airport on the other side of a massive estuary from the capital? And the answer is, well, they were shipping the stuff they needed out of there through that port. And on the ferry ride, you know, it was noisy, and you know, I was thinking, they're all going to die. This young woman, who I wanted to say to her, when I say young woman, she's probably late 30s or something. I really wanted to say to her, can I please stick you in my carry-on luggage, you know, or do your parents know? This is a grown medical practitioner with a subspecialty. That's what I was thinking. I didn't say it. And the nurses did die. They're in their early 20s, you know, and you know. But on the way out, I just was seeing all this stuff in my mind. I mean, literally, and then, you know, I had these other acquaintances, Sierra Leoneans, and one of them, an infectious disease doctor, you know, he died on July 29th. And that's when, you know, that's when really I said, Arthur Kleinman, by the way, wrote me a letter, an email, which I have. It shames me to this day, early August, saying, you should do something about this. And I went, well, you know, we don't have any experience. Or, you know, and we were working with these two community-based organizations, one in eastern Sierra Leone, one in eastern Liberia. It was bullshit. Because I knew that you needed staff, space, and systems. These were small community-based organizations. MSF was already hollering, right? And that's when, you know, we started to push the Board of Partners in Health to make a commitment, a long-term commitment. And so this is a good chance for me to say to Joanne, especially, you know, thank you, you know, for her clarity of vision. Now, this was brought up by the DRC epidemic. That's what you were asking about. I'm just saying, I think the lesson that I would take out of the West African epidemic, as just one physician working with, in the end, some thousands of mostly Ebola survivors, nurses, doctors, again, clinicians, but also epidemiologists, drivers, people learning how to count, or knowing how to count, but learning how to be involved in this work. The message I would take is that, out of this, is that, again, it's really important to integrate prevention and care, because people, when they're sick, aren't looking to be sprayed, controlled, counseled, told about bushmeat, on and on. That's not what they're doing. They're looking for someone to look after them.
They're looking to survive.
They're looking to survive, and they're looking to have their family survive. And when they see that the quality of care is not good, they're going to flee, right? Because control without care, you couldn't get away with that in the United States or Canada, maybe Canada. No. Well, I'm just saying, you know, SARS, everybody made a big fuss here, right? You know, and so I'm just saying, control without care, I think, is what amplified the epidemic.
And the fact that 19 people have died tells you that care probably wasn't up to mark.
Not only that, not only is the case fatality rate completely different from what we saw among, for example, you say Europeans, Americans, whites, you know. It's the same or worse, but also just to read the language of the reports. In the ones I read, there's no mention of quality of care at all. It's, again, these rural people, we've got to control it, and we did contain it. That's, you know, this is reference to the last one. It's really, you know, I hope and I expect it will be contained, right? But that's not going to be, that doesn't have to be at the expense of actually trying to take care of people so that the majority survive.
Sure. So we now have time for questions from the floor, and we're going to begin with the board of School of Population Global Health, members of the board. Victor, would you like to start with a reaction or a comment? Can we get a mic here?
Paul, what I've learned from you, believe it or not, I learned a lot of things from you, is your great commitment to equity. And so I thought if you're going to ask the three biggest questions, number one is...
So you're the one who said that.
Yeah, no, I did. He's the one. It would be equity.
Yeah, and why not? Because there's going to be technological advances. Thank God. You know, a lot of that comes from work like yours, basic investment in discovery sciences. What's our plan, our equity plan to get that, whatever that may be? You mentioned already the vaccine, something that wasn't around before 2014. Now we have some idea. What's the plan? Was that a full question?
That's a nice and
Number one.
concise answer. Thank you.
Let me just say, as you said earlier, concision is not his strong suit.
Maybe you can pass this to Joanne.
Joanne? This is Joanne Liu, president of MSF and a McGill alumnus.
Well, hello, Paul, and I'm glad we sing each other. I think that I miss, unfortunately, the beginning of your talk, but I think it'd be good I'd like to hear from you, because we wrote an article together, and can you talk a little bit more about TB and what does it need to kick ass about TB and get it as a priority in the global health agenda?
You know, so to kick ass on TB, she doesn't look like she's going to say that, but then, you know, all you have to do is wait a second, and out it comes. You know, I remember so, by the way, of course, I was going to say, well, Joanne was in Canada, and I was in Mumbai, but I don't know where Joanne was when we were going back and forth and writing this. And we do not want to tell any victory narratives about tuberculosis. How could we? It's the leading infectious killer of young adults. It's scandalous, you know. And Joanne was saying, you know, without political will, you know, it's a dead letter. And of course, we could have written that every year in the 15 years we've known each other. And one of the questions, I think, is a test, that's all. Because there's not, as you said, she does scold me when she needs to. There's no technological fix for this, right? It is about poverty and weak health systems, and we know that. But it's a test case when you have a new diagnostic or a new therapeutic, right? If you had a new vaccine, that would be all the trifecta, preventive, diagnostic, therapeutic. So it's a test case. There are two. And I can't tell you how dreadful it was to see those young people in Mumbai, one after the other, 15 years old, 23 years old. I mean, the oldest one was in his 40s and was turned very dark by a terrible drug called clofazimine, which, you know, only, I mean, this is like, the drug should be long gone, right? It's just so terrible. I mean, you can imagine the impact on their families because they're also dying or have died of TB. It's airborne, blah, blah, blah. And one young woman, you know, and this is through translators, right? Some of them spoke English, but, you know, I forget that it was being translated because it was so vivid and dramatic. And, you know, for them, kicking ass is still going to be bringing them to cure, right? And that was the big problem. And these are people who managed to make it to a subspecialist clinic in a huge city,
yeah.
See one of the world's great specialists, right? The world's very best. I mean, anywhere he would go, he would be, he's just an amazing person as well, right? And to pay for lab tests, he had a little foundation, but, you know, these people had all been impoverished already by their disease. One girl who was the victory story had lost her hearing completely and had a cochlear implant, which I thought was terrific that she had that. She came here?
No, she came here, and we are actually fundraising for her cochlear implant. Nandita.
Bless you. Yeah, she was just fantastic. But, you know, so kicking ass for them and their families is going to be paying attention to the fact that as much as maybe some of them are really concerned about policy in Moscow or the drama of an outbreak in Alabama, but what they're really allowed to be concerned about is their survival or the survival of their daughter or whatever. So those efforts shouldn't be modest. We are working with MSF on a very large multi-country effort to roll out new therapies inside multi-drug regimens and evaluate them at the same time, right? But it's been one problem after the other around funding. So, you know, again, kicking ass is going to mean something for those individuals, something for, it shouldn't be hard for MSF and Partisan Health to find the resources to take care of people with this deadly airborne disease and document it, right? But it is. Then, of course, it's not just about that family, Zarir's patients, our current and future present patients, but as Joanne has said, it's about when is it not going to be okay to have people die of something that's, we've known,
Curable.
you know, it's curable, and you know, again, if you can be optimistic, which I am, you could say, well, it was suddenly okay after all this time, not okay for Canada not to think about its Indigenous people publicly, or it was not okay, you know, there are some things that keep happening that I think, I mean, it's not okay for the United States of America not to have a lynching memorial in Alabama, you know, that honors the memory of people murdered because they were black. So I'm a believer in human progress, and kicking ass is going to be sticking with progressive values while not forgetting individual patients.
Thank you. Anyone else has a question for Paul? Yes.
On a global level, the most pervasive disease affecting millions of people is probably malnourished women who give birth to millions of children with no futures and the risk of early onset disease. Now, we're not talking, my question is, we're not talking about sophisticated problems like cancer or Alzheimer's, but maybe we aren't spending enough time on basic things like food and water because we're more sophisticated in dealing with more complex issues. How do we get back to basic human values and survival for millions and millions of people?
Well, first of all, thank you. I'm arguing, of course, that we're not sophisticated about taking care of complex problems. So we're not sophisticated about taking care of simple problems, and we're not sophisticated about taking care of complex problems. So these are not pitted against each other. It's really, how are we going to invest in health and well-being? And, you know, sometimes we're lucky and, you know, that you don't have to worry about treating cervical cancer, including metastatic disease, because you already prevented it with a vaccine sometimes. But somebody, you know, if I may be permitted just to say this, you know, when I was a medical student, and I apologize for those who heard this, I was hit by a car. And I was hit by a car, the last words out of my mouth to my best friend, who was the founder of Partners in Health, Todd McCormick, were, "Todd, you're not paying attention to me." I was not paying attention to the cars. And you don't have to be a physics major, P equals mv squared. The cars always win. So, you know, I could tell I had a broken leg after 3 years of medical school. When it's shaped like a chicken's, bad sign. But, you know, I had a complex medical problem. I had a bad fractures of all the bones in my leg. And, you know, if the emergency, you know, if the ambulance, finally the ambulance got there, I'm in the middle of the road, so there's a traffic jam. Before the pain hit, I did apologize to the driver who hit me, because it was my fault. And my friend Todd is going, "Shh, you could sue him." I went, "Yeah, well, except that anyway, then the pain hit and I was less chatty." By the way, until the morphine kicked in, there should be a right to morphine, or palliation. I'm not kidding. There should be a right to pain control. But what I felt after having gone back and forth between Harvard and Haiti was that, you know, if those, they were both men, if those guys, EMTs, had leaned over me and said, "You should have looked both ways before you crossed the street," I would have been quite cross, you know, and they didn't, you know. But when we say to someone who has a complex medical, like a child with leukemia, you know, we have to pay attention to malnutrition, you know, it would be kind of like if I'm seeing patients and they're, you know, one patient leaves and the next one comes in, I said, can you believe that last patient? I hope your problem is not as serious as hers, you know? And, you know, we don't do that, and I don't think we should do it in public health or health. I think we can address malnutrition, we can address prenatal care, we can address safe motherhood, including, you know, obstructed labor.
And offer trauma services.
And offer trauma services. And we do, when, at our best selves, wherever we are in the global economy, we do.
Who else has a question? Can you come up to the mic, please?
Hi. My son has a question.
Hey there.
Go ahead.
Before he asks his question, I'll just preface a few things, saying that I read your book, AIDS and Accusation, in 1999, Dr. Farmer.
Whoa, I like this guy already. Did my mother send you?
And it changed my life. I've since become an ID physician, and I did a master's in anthropology. That's how I met my wife. That's how we had this little guy. So that's a preface, and now his question.
You're all from my first book, AIDS and Accusation, young man.
And so this is my son who has a question for you in French.
Vas-y, enfin.
Est-ce que vous avez vu des lions en France?
En Afrique.
Est-ce que j'ai vécu en France? Ça ne se voit pas. Mais oui.
Est-ce que vous avez vu des lions en Afrique?
Oui, oui, et j'ai beaucoup aimé. Alors, comment tu t'appelles, toi?
Damien.
Daniel.
Damien.
Daniel, je t'en remercie de tes questions. Et c'était un grand privilège et j'espère que toi, tu auras l'occasion de le faire aussi. Thank you, Daniel.
He's definitely destined to study in our School of Population and Global
we'll
Health
take him
in
to
future.
Harvard and then we'll share him.
Go ahead.
Well, I don't think I can beat that question, but okay. And I'm trying to organize a little bit my ideas because I have a lot. There's a lot of information. Of course, there's a lot of doctors on the room. I'm a journalist, so it's a little different, my point of view. Do you think that there's a lot of movements right now in the world, not only global health, but a lot of issues worldwide, that right now are very successful because maybe they've been marketed the right way? Do you think that maybe global health, it's one of these subjects that maybe do need more of the support from normal people? When I'm saying normal people, it's like not doctors, but another kind of professionals, like in my case can be photographers, but a lot of things, because I just feel that right now, these days, the current subjects in the world, like privacy, like web privacy and all these, are things that are present in the media all the time. Do you think that maybe global health need this approach to make these subjects more current and to make like more current between like people, not necessarily doctors, but other kind of professionals?
Thank you.
First of all, I'm so glad that you brought that up. I know that we're running out of time because I wouldn't want to miss a chance to underline the importance of the engaged citizenry's participation, like Danielle. And by the way, however, as an aside, I will notice that Danielle's father read AIDS and Accusation, meaning obscure stuff still sometimes reaches people. To be serious about it, we're clearly failing to communicate effectively. Like I said, I have my experience of coming to this country or living in my own, and I just, coast to coast, I meet really nice, kindly people, right? And I've had a few doubts in past few years. Well, how much do you really know? Are you in some bubble? But if I'm in a bubble, it's not a bubble with, Harvard professors. It's a bubble with Haitians and Harvard professors and people in Texas who would invite me to give a talk at a university, and people in universities from UNC, Duke, UCSF. It's not your standard bubble. And I come from Florida, and my family still lives there. It's not a real bubble in the sense of a white, liberal, elite bubble. Although, as my daughter said, but Dad, you're not really a white liberal, you're pink. Thank you, David. So I think that there's this, and I'm sure it's the same in Canada and Europe. Me going on about the horrors of colonialism is not going to help us bring these issues of today and tomorrow and kicking ass on TV, for example. It's not going to work to get people of goodwill engaged. And really, that's just to echo Martin Luther King, letter from Birmingham jail. It's going to be our silence and that's going to be the complicity, right? It's going to be people of goodwill who think that they've got the right views on things, who just don't do enough to give everybody a chance to engage in health and social justice. And this is a chance for me to say again to Ruth and Victor, thank you. To David and Tasha, I always get it right. Just focus not on the spelling. And everybody, all the students and faculty I met today, and as you launch this new effort, which is what we need to keep focused on equity. And Madhu, thank you so much for having me here.
And Paul, you're such an inspiration to all of us.
Thank you. Thank you very much. Thank you. Oh, Mark. Thank you. Thank you, my brother.
Thank you. That was amazing. I also want to acknowledge Ruth and Cooper-Dzau for their incredible generosity, not just in terms of creating this award, but helping us with this school, which is a huge undertaking for us. And looks like we already have a flying start to our board, which will meet tomorrow. I would like Dean Eidelman to come and close, and also to mention that Paul has another engagement that he would need to leave soon after. So
just give me a second. I just got to go back. So it falls to me to end the event. So first, I have to give away the McGill swag. Exactly.
Love it.
Thank you very much. So just on behalf of everyone here, I want to say how grateful we are that you were able to share your very linear and coherent description of things. I also want, on behalf of all the other Lord of the Ring fans in the room, thank you for shouting that shout out on multiple occasions for one of my favorite books. But I mostly want to thank you for the inspiring way in which you showed us the importance of issues like equity, social justice, and the fact that we're all part of the same world that is often forgotten, I think, by many, especially those, unfortunately, who have the power to make decisions, who think that the borders that we invent between countries are actually real things with, like walls that some people talk about, when in fact, when it comes to health, and especially to infectious disease, that nothing could be more abstract and ridiculous. So on that, thank you so much for making the time to be here with us. And thank you, Madhu, for being such a charming questioner and so patient. And thank you all for being here this evening. Have a great evening.